Next one.
Sir,
Yes,
good evening,
Samuel.
sir. Yes, sir. Good evening, sir.
Good evening. Go ahead.
Sir, my topic is adductor canal block, sir.
Huh.
Okay. So
Are you
adductor
doing
canal
it
block.
in your hospital?
Yes, sir.
Very good. Go ahead.
The adductor canal block involves injection of local anesthetic into adductor canal deep to sartorius muscle and is technically easy and a reliable method for blocking saphenous nerve.
Very good.
This may be useful for post-operative analgesia after knee, foot, or ankle surgery, usually in combination with popliteal block. It will also result in a block of the infrapatellar nerve also. And anatomy, applied anatomy, the adductor canal, also known as Hunter's canal or subsartorial canal, is an aponeurotic intermuscular tunnel in the middle third of thigh. The canal is roughly triangular in cross section and is bounded by three muscles. The quadriceps anterolaterally, specifically vastus medialis, sartorius medially, and adductor magnus posteriorly. This muscular tunnel extends from upper anterior thigh at a point at which sartorius crosses adductor longus to the lower and medial thigh. Approximately 12 to 14 centimeter proximal to the knee is adductor hiatus, which is a distal opening in the adductor magnus muscle. Within this canal is the femoral artery, femoral vein, the posterior branch of obturator nerve, and the branches of the femoral nerve, specifically the saphenous nerve and the nerve to vastus medialis. At the adductor hiatus, the femoral vessels passes deeply before leaving the canal. The femoral artery changes course to this deeper plane to become the popliteal artery and the saphenous nerve, and travels with the smaller descending genicular artery to emerge from the adductor canal to eventually diverge from the artery and become subcutaneous. It is this sudden change in depth that is useful indicator of the canal's distal limit, and therefore the optimal level to form the adductor canal block. Once the saphenous nerve becomes subcutaneous, it follows the saphenous vein along the medial side of the knee to the lower leg. The posterior division of the femoral nerve sends branches to the quadriceps muscles, particularly vastus lateralis and vastus intermedius. Together with the saphenous nerve, each one of these branches give rise to articular nerves that provides sensory innervation to the knee joint. It is for this reason the saphenous nerve block does not provide as good analgesia after knee surgery as the conventional femoral block at an inguinal level. Indications: it's a low volume block. It is 5 to 10 ml. Knee arthroscopy, ACL reconstruction, lower leg foot angle surgery involving the areas of skin supplied by the saphenous nerve. High volume block, 20 to 30 ml. It is total and unicompartmental knee replacement. Its contraindications is absolute contraindication is patient refusal, inflammation or infection over the injection site, and any allergies. Relative anticoagulation and bleeding disorders, and pre-existing any peripheral neuropathies. And it's a general preparation. Before starting, ensure that appropriate indications for the subtaurial block and no contraindications. Consent should be obtained and advise them on the likely duration of the block. Ensure the site is clearly marked and the patient is monitored and the IVS is obtained and that appropriate assistance equipment and drugs are available. Specific requirements: equipments required, that is 22 gauge, 100 millimeter length, short wavelength regional block needle, skin antiseptic solution, sterile gloves, 1 to 2 ml of 1% lignocade for skin infiltration in awake patients. Low volume block is 5 to 10 ml of long-acting drugs, example 0.25 to 0.5% bupivacaine. And the high volume block is 20 to 30 ml of long-acting drugs. The portable ultrasonograph machine. Procedure: confirm the operative site and side up with patient. Check limb is marked and corresponds with information on consent form. Apply full monitoring and secure IV access. If it is required, proceed with sedation or induction of general anesthesia or spinal anesthesia as per plan. Position patient supine with knee slightly flexed and leg externally rotated. Frog leg position. Clean the area with 0.5% chlorhexidine spray. Stand to the side of the patient to be blocked with ultrasound machine on the opposite side and screening facing you. Place a high frequency UST probe on the anterior aspect of the patient thigh, approximately midpoint between the inguinal crease and the medial condyle. Identify the femur, usually at a depth of 3 to 5 centimeter, though variable, and move the probe medially until the trapezoid or boat-shaped sartorius muscle is visualized. The femoral artery lies just under this muscle within the adductor canal. And the saphenous nerve is almost always too small to be reliably imaged, and the aim of this technique is therefore to deposit a local anesthetic under the sartorius and around the femoral artery within the adductor canal. Optimize the image, adjusting depth, gain, and frequency settings are required. The appropriate probe position is just proximal to where the femoral artery divides posteriorly, and a probe should be positioned perpendicular to the artery. At this point, the femoral artery should start to pass deeper to form popliteal artery. The vastus medialis muscle lies anterolateral, and the adductor magnus muscle posteromedial, and the sartorius muscle medial. Use an in-plane approach from lateral to medial, ensuring that your tip can be seen at all the times. Advance your needle into adductor canal. This can be achieved by traversing sartorius or vastus medialis, and aspirate and inject test dose of 1 ml of local anesthetic solution. Observe the spread of the local anesthetic to ensure that your needle tip is definitely within the adductor canal. We cannot clearly see the spread of the local anesthetic considering intravascular placement of needle or reposition. And continue with the remainder of the injection and aspirating every 5 ml. Post-procedure care. Continue monitoring patient carefully, looking particularly for signs of local anesthetic toxicity. Document the block clearly, including whether done awake or after GA or spinal, at the side and site of injection needle used, everything. All patients should be seen or contacted post-operatively to ensure that the block has gone off completely. And
Very good.
Complications.
Go ahead.
It's common to all blocks: block failure, intravascular injection, local anesthetic toxicity, nerve damage, infection, allergy to local anesthetic, and methymoglobinuria when using prilocaine. And specific to adductor canal block is vascular puncture and hematoma. Thank you, sir.
Okay. So can this block can it be used for operative procedure as a sole anesthetic technique?
No, sir. That's lateral side.
It's only an adjuvant. Okay.
Adjuvant,
It
yes,
can
sir.
be given for post-op pain relief and early mobilization, especially after knee surgery. Okay. This has become popular after TKR surgeries became very common. So they wanted to mobilize patients as early as possible without motor blockade, with alone, sensory blockade alone. That is the reason why this block has become so popular, to produce only sensory analgesia without motor blockade. Full power will be there. Patient will be able to ambulate themselves easily. What is the other name for sartorius muscle, commonly called in anatomy classes? They would have taught you.
What name, sir?
Which particular professional uses the sartorius muscle more?
Subsartorial block.
Huh?
Subsartorial block, sir.
No, I'm not asking about the name of the block.
Taylor.
Huh? One particular professional people use the muscle sartorius in their profession.
Taylor, sir.
Taylor's muscle. Very good. Called Taylor's muscle. When they, in olden days, tailors used to pedal their machines, isn't it? During stitching, they used to pedal the machine with the pedal at the bottom. So they use the sartorius muscle mostly for doing that pedaling. And that is the reason why it is also called the Taylor's muscle. And you have mentioned all the important points. I'll just show you some pictures to remember how it is being done, and not very detailed on the border. So the very short presentation on adductor canal block. So it is an interfacial plane block, adductor canal block, and it is mainly used as an adjuvant for analgesia. It cannot be used as a sole anesthetic for any major surgery, but it is used as an analgesia for surgery on the knee or heel or lower leg and ankle. And it is mainly used for post-operative analgesia following knee surgery because of pure sensory blockade. And that is the reason why it cannot you cannot use a nerve stimulator here, because sensory nerves are not stimulated by your you cannot have an objective evidence of the nerve being stimulated unless it has a motor component. So it is mainly done using ultrasound. Without the ultrasound, you cannot do that. So it is a part of sensory saphenous nerve is a part of operator nerve which travel through the adductor canal of thigh. And by blocking this with local anesthetic, we can provide analgesia of both these nerves, and it preserves the quadriceps strength, facilitate ambulation and post-operative rehabilitation. And general considerations common to all peripheral nerve blocks that should be written. As we said, apply all the monitors, keep all emergency drugs ready, and do the aseptic technique, identify drug doses and mode of administration. Everything should be calculated and kept ready. So the anatomy is it's a muscle which is descending lateral to medial aspect. So it is as anterior superior iliac spine to medial part of the knee, runs like that. Which other organ in the body has supposed to be the same length as sartorius? Anatomy, they used to teach 3 organs usually having the same length as sartorius in a person, or whatever be your height. If your sartorius is say 18 inches, you will have the same 18 inches in 2 other organs. Can you tell me which are the other organs which have the same length? Okay, you can tell me later. Sides of triangular canal, the vastus medialis, adductor longus, and the sartorius. And the contents are these are the 3 contents. The nerve is blocked with the patient in supine position with the thigh abducted, externally rotated, and you can see this is how the leg should be positioned, and the probe is used, and it is from lateral to medial insertion. Okay? This is the lateral part of the thigh, this is the medial part. So this is out of plane, you are little away from the probe, not just underneath. And once you pierce the sartorius muscle, the saphenous nerve is sometimes very small to be identified with the probe. The image will not be so. But the femoral artery you can easily see with the pulsation and things. And even if you just deposit the local around the femoral artery, it will go and catch this. So this picture will tell you this is the femoral artery, this is the sartorius muscle. So patient, the needle is coming from lateral to medial, and very close to femoral artery, if you deposit saphenous nerve will be blocked. And as he said, the techniques are low volume, high volume, depending upon the extent of nerves that you want to get blocked, and that will be useful for doing this. So this is a very short topic that you can. Whatever he has prepared is all given in the Nagaswamy article, and that can be reproduced for exam sake. So for class discussion, I think I will stop with this topic. Okay. So we go to the